All right. Firstly, I'd like to thank the organization of the event for the kind invitation. I don't have any slides or images for this presentation, so you get to pay attention to my voice and my face and my accent for 20 minutes. Well, look you, I guess. Feel free to ask questions at the end of this presentation. I know that there's going to be a time for that. I'll be around to answer if any. So today you have sessions on inherited retinal diseases in the macula, particularly, and age-related macular degeneration. I think is the day after. So we are all talking about macular diseases here, right? Which is this extremely important section of our retinas that's crucial for vision. And in one end of the spectrum, you have age-related macular degeneration, which, as I'm sure you all know, is a multifactorial disease, meaning that multiple factors influence its development and its progression as well, from genetic factors all the way to environmental factors, right? So we're talking about things like diet, smoking, and so on. So we don't consider in the ophthalmology field age-related macular degeneration to be a pure genetic disease. However, I'll walk you today through an actual 100% rare form of genetic disease that was considered by many people in the past as an early form of age-related macular degeneration, and for what it's worth, it may as well be. So I'll be talking today about autosomal dominant drusen and some of the work that we have been doing in this specific form of retinal dystrophy. Now, this has been called in the past by many other names: Malatia leventinesi, familial dominant drusen, or Doyne honeycomb retinal dystrophy. And it gets this name as it was first described by this researcher, this brilliant researcher, I should say, named Doyne in 1899. So that's, more than a century ago. This has been a long time. And where does this name come from, right? If you have ever read anything about age-related macular degeneration, you will have heard about drusen, which is in some ways is the hallmark of the disease, really. And these are small whitish yellowish deposits that patients developed in the retina, which is this very important film-like tissue that we have in the back of our eyes that has many millions of light-sensitive cells that are crucial for vision, right? They're necessary for vision because they process the light that comes inside our eyes. So that's where the drusen name of this condition comes from. And then we have autosomal dominant, right? It's autosomal dominant drusen. And the autosomal dominant comes from the fact that this condition is inherited in a dominant manner, meaning that a person would only need a mutation in one of the chromosomes coming from either the mother or the father. This creates a gene that does not really work correctly and essentially negates the normal function of the healthy gene that's on the other chromosome that you have. And I always tell patients that the best way to think of genetics is to think that we all have a blueprint or a set of instructions or recipes, if you wish, that makes us who we are. Half of this information comes from our biological mother, the other half comes from our biological father. On the specific case of autosomal dominant drusen, for this condition to happen, you need to have a specific mutation or a change in a gene named FMP1, EFMP1. In case you're wondering, it stands for EGF containing fibulin like extracellular matrix protein 1. So yes, let's definitely not go there and keep the FMP1. It's much easier. And this gene is an interesting one because of What causes this disease is a single mutation on a single amino acid that's within this gene. Or if we go back to the recipe, right, the parallel with the recipe, the blueprint, a single ingredient in this recipe has been altered, if you must. And it's a specific change in the amino acid number 345. Now that the basic and more, I would say, more sciencey things are out of the way, let's talk about the disease, right? What exactly is this disease that I'm talking about today? So, as an overview, patients affected with this condition will usually develop this drusen earlier in life, before it would be expected for patients with age-related macular degeneration, for instance, right? And that's why in the past, and we still call it these days, honestly, familial drusen, right? Most reports to date, if we look at what's in the literature, what are the reports that we have, the scientific reports, they say that patients do not experience symptoms until the fourth or fifth decades of life, after which they start to complain of some unspecific visual stuff, right? Or things like floaters, distortion in vision, wavy lines, reduced central vision, which can be caused by many, many different things, right? Now, later in life, patients may get to a more advanced stage, right? To a level of vision that is on the 660 line in the reading chart, if you remember the reading chart of the visual acuity test. And essentially means that you need to increase or zoom in 10 times more than you should, to what we would expect for normal individuals or individuals without this specific disease in the retina. That's what I mean by normal. However, the natural history of this disease was still a bit insecure, right? And mostly considering, um, because in the future we usually describe this as a mild condition in terms of progression. And we recently, what we did is try to look into this in detail. So I guess just backtracking a bit now, because this is relevant to everything that you will have listened today and during the weekend. We had a lot of advancements in the field of retinal imaging, to a point where now it is routine to acquire high resolution tomography scans, for instance, right? And other forms of imaging, some of which you may have done already, that flash some bright lights, right? Patients don't really like this one. And these allow us to see changes in the underlying pattern of pigmentation in the retina, in the macula particularly, right? We call this fundus autofluorescence. How could this help us here? Well, it turns out it helps a lot. And the reason I'm saying this is because we can now, in a much more detailed and comprehensive manner, try to understand the natural history of conditions like this one, right? And many other forms of retinal diseases as well, not even inherited, all other forms of retinal disease. And that's exactly what we have done, right? We're trying to understand the natural history of this. And what better place to do this than Moorfields? We have a large data set with patients affected with inherited retinal diseases, which has been collected over many decades. And we were able to look back in time in a retrospective way. And we found in our data set around 44 patients with this form of retinal disease. And we try to standardize this group of patients in the best possible way we could find. So essentially, try to put all of these patients within a basket that has a pattern and makes sense for us, right? And so, because you need to realize that we are looking back in time, we're not looking forward. So there's no standardization in the way that the patient was seen or the image was acquired, right? So we found that the mean age in which symptoms start is indeed as expected, as previously described. So 40 years of age, that's the average where patients start to have symptoms, and that the main starting symptoms were reduced vision and distortion in central vision. The Average time that these patients were followed in the Morpheus database was 8 years, which is huge, right? This is the mean, which is a long time. The vision remained relatively preserved throughout this follow-up. We're talking about around 618 of vision, which, if you ask most of my colleagues who work with macular diseases, they'll say that it's a quite preserved vision, and they would be correct. We have also identified several disease stages in the retinal imaging, so we can now stratify this disease much better. And this will you understand why that's important. What was really different to us, and what was the main thing, I think the main finding and the main relevancy of this, first is that we are in some ways uh, asserting what was previously thought of this disease. So that's exactly right. In some ways, it's mild. In some ways, the patients progress very, very later in life, and the vision seems to be preserved. But what was different to us is that 12 patients at some point during the disease progression or the natural history of the disease, if you must, developed a complication that is much common in age-related macular degeneration called choroidal neovascularization. This is a big name, right? And in essence, what this means is that fine vessels grow in the back of the eye, and these require treatment with injections into this jelly inside our eyes, right? We call this the vitreous. And these are the exact same injections that are used for the wet form or the exudative form of age-related macular degeneration. Now, coming back to our patients, 12 patients developed this complication, three which had this in both eyes. So it was bilateral in these three patients. And this represents 27% of our cohort, meaning that more than a fourth of our group of patients developed this. It may not look like much, but if you think about this for more than 30 seconds, you realize that this means that if you have 1,000 patients with this condition in Europe, for example, is a completely random example, uh, but we're based in Europe. More than 250 of these will have choroidal neovascularization, and will actually need an active treatment with injections, right? So this is a big issue for two reasons, right? Firstly, because the prognosis of patients when this complication was present was much, much worse uh, as compared to patients who did not have it. I'm talking about patients at 50 years of age having 615 of vision when this wasn't present. That was the average vision at 50 years of age. But when this complication was present, the average vision was 660. That's a huge difference, right? The second reason why having this complication is a big issue is because we always told our patients, right, that the prognosis was relatively good. And in fact, it still is, provided there's no choroidal neovascularization, provided that these vessels do not grow in the back of the eye, right? Our data suggests then that it is necessary to have a closer follow-up of patients with this specific form of macular inherited retinal disease, maybe at least once a year, right? We always thought, well, there's a risk of neovascularization, but it's a mild thing. They will realize when the vision changes. And actually, we are going the other way around now. We're saying, okay, you know what? We have this Ensler grid here, which is that grid that has the vertical, the horizontal lines, or you can just get a quotation that you like, put on your fridge, and compare your vision in the right and the left eye every a few like 4-5 days a week. You can do that. And if there's any changes in your vision, or if there's wavy lines or distorted lines, you should go immediately to an A&E, because they need to do scans of your retina to see if this complication actually showed up, right? And to explain to patients, right, what the symptoms are. And that's another thing that patients need to be aware, right? And in case you're wondering, the symptoms are distortion, wavy lines in vision, sudden decrease in the central vision. So in a lot of ways, closer follow-up is necessary. I think it's one of the big um, conclusions that we got from this. And as you will know, part of what we do, and I would say a significant part of what we do, is raising awareness to things like this, right? And the beauty is that the beauty about the scientific method is that we learn things as we go. So it's not that we are saying that it's not mild. No, it's still mild, but now we learn that up to a fourth of patients, if followed for a long enough time, will have a complication that requires a treatment that's very effective. But if left untreated, the prognosis is much worse. So the natural history will be worse, the final vision will be worse, the disease will progress faster, and so on. Now, the good news is that, remember when I told you that this disease is caused by a specific change, in one amino acid, right? And we call this a point mutation. Well, this is the type of disease that is extremely promising for treatment with new technologies such as gene therapy, or even more specifically here, gene editing, because that would mean that you can directly target that point mutation. So this opens up a huge avenue for treatment, and there are a few groups trying to tackle this, including some of my colleagues here working with Jackie van der Spuy. She's doing a lot of good work, great work in this specific type of retinal dystrophy, and we are learning a lot more of the pathways to which this causes disease. And apparently, it seems that there is a lot of convergence with the pathways that actually cause age-related macular degeneration. How cool is that, right? Because that means that FMP1 may be one of those genes that influences patients developing age-related macular degeneration. We don't know. These are things that we are still learning. And another thing that I wanted to say, and I'll leave you with that thought, is that on our cohort, most of our patients, and we're talking about like three-fourths of our patients, were female patients. That's interesting because age-related macular degeneration, there's some evidence, some epidemiologic evidence saying that it's more common in females. Also, there are some inherited forms of retinal disease that have been just shown by some researchers here at UCL, actually. And we are involved in this project too, that these conditions are more common for some reason in females. And it's another interesting finding. We can't really explain why. Could it be hormonal changes? We don't know. But we're still learning as we go. The future is really bright, and we're learning a lot as time passes. Hopefully, there will be treatments for these conditions in clinical trials very soon. Thank you very much for listening to me today, and I hope you have a nice event and enjoy your weekend.